Welcome, everyone. My name is Haley Buckner. I'm a registered dental hygienist and a preventive care consultant supervisor for Elevate Oral Care. Our speaker today is Dr. Jeremy Horst. Our team of preventive care consultants have had the honor of listening to and interacting with Dr. Horst at our last Elevate Oral Care National Education meeting. Dr. Horst is a practicing pediatric dentist and a biochemist known for investigating the strengths and limitations of silver fluoride therapy and helping to develop smart fillings. His mission is to reduce suffering from tooth decay by driving the development of better treatments and preventives. In his teaching and clinical practice, he focuses on maximally effective, minimally invasive techniques to stop dental caries and create an easy relationship to dentistry for children and people with special healthcare needs or uncontrolled caries. It's an honor to have such an expert in this field to share his knowledge and experience here with us today. So Dr. Horst, I'll pass it over to you.
Thank you so much, Haley, and thank you everyone for joining. It is such an honor to have each and every one of you join us this morning. I appreciate your time. You could be doing lots of other things at this time, and it is so encouraging to the work that we've been doing and to the success that we've been seeing with these treatments that I'll discuss today, that all of you have shown up to join in. Hopefully we have a robust question discussion session at the end of the course. We have quite a bit of material. I hope that this can provide a solid overview of, in particular, the use of silver fluoride to control cavities, dental caries, and I hope to be of use to you guys. So the title is Non-Restorative Treatments, and we'll talk about what that is, but as a first-line therapy for cavities. And so taking a lead from infections, from asthma, from the whole of medicine that has different lines of therapy where operative and surgical interventions follow the attempt to use medicines first. If you would think about, God forbid, if you got sick, you would probably want to try some medicines before you tried surgery. And so this has really been the space where folks have been developing non-invasive or minimally invasive treatments to treat cavities, just like we have for asthma, for diabetes, for many other, for infections, we have antibiotics and so on. So that's kind of the place that it fits in. Next is my disclosures. I have been a researcher and a clinician focused in dentistry for about 21 years now, if you include being a dental assistant and being a dental assistant during in college and all that fun stuff. And in particular, over the last decade, my research work and some of my course teaching has been funded by the Facebook people and by Elevate Oral Care, who's been a great friend to dentistry, in my opinion. And they've been very generous to support me. I am therefore biased towards them, by folks like the National Institute of Health, who, just biases come from all of these places and including private practice. So I am practicing, well, up until a few weeks ago, my main income was coming from private practice. So we all bring our biases. And in particular, I wanted to share that I think I feel comfortable making a few statements about the current pandemic, COVID-19 and SARS-CoV-2, because I spent 5.5 years in the laboratory of Joseph DeRisi, who discovered SARS-CoV-1, and it's one of the big infectious disease labs that has been bringing forward virology for the last 2 decades. And in his lab, I discovered the association of some viruses to disease, and about a third of my coworkers were serious infectious disease virologists, and so I feel that it's appropriate for me to make a few simple comments about what we can do in dentistry, what some of the risks to dentistry are from this particular virus that's hitting us now. So an outline for the rest of the time together is just a couple of those public service announcements that I led into in the last slide. A overview of the non-restorative caries treatment. What does that mean? What is that? And then we're going to go in pretty deep to silver fluoride. And so the first is that there was a study done that I mentioned in the last presentation on aerosols generated during dental procedures. So if you look at the bottom left, about 51 years ago, just down the road from where I'm sitting right now in San Francisco, they stuck people's heads into chambers and worked on their teeth, doing various things, and checked around the corner. From the chamber, they sampled the air, so you weren't having a splatter of spit and water. You were checking the air in the area for bacteria. And the idea is that dental procedures they put microbes like bacteria and virus into the air, and that the particles are small enough that the viruses and bacteria actually sit in the air. They are supported in the air and potentially could be transmitted that way. And this was really well established for tuberculosis, which most dentists had 150 years ago, and thankfully we don't these days. But they did a study on how many bacteria were put into the air by sort of patient-based behaviors. So just breathing heavily, gargling, clearing their throat, speaking. And as you can see, they were able to group these behaviors, these actions, into 3 different groups based on how many bacteria they put into the air. And coughing produced 36 bacteria per minute into the air. And brushing the teeth, the patient brushing their own teeth, put about 2,500 bacteria into the air per minute. And so this is relevant to what we do in dentistry. And of course, they didn't just look at these things, they looked at dental procedures as well. Pardon me. And so for the same technique with a person's head in a chamber and the face exposed, they used some gloves to get into the chamber and did the following procedures. And in particular, it was surprising to me that doing a prophy with a normal rubber cup prophy and pumice produced quite a bit of bacteria into the air. In fact, more than just coughing. And that drying the teeth with an air spray, just air drying, put actually twice as much bacteria into the air as that. But just looking at the teeth and even careful scaling really didn't put very many bacteria into the air either. And so the message from this is that, yes, this and all the previous studies in looking at aerosol production in dentistry looked at bacteria, and we don't know exactly how this corresponds to virus. Are there 100 times less viruses in the air than bacteria because we're dealing with the plaque? Are there 100 times more because viruses are so much more abundant when there is infection? We really don't know. But assuming kind of the worst case scenario, it does seem like if you don't disturb the plaque very much, or if you do using a hand instrument like a scaler, it seems to be a pretty minimal risk compared to the other procedures that we do in dentistry. And so I just find this study incredibly useful to frame how we are going to go forward after we all start reopening, and what we can do during urgent care procedures. And so it does seem like using water in any way, shape, or form, and using handpiece in any way, shape, or form, or agitating the plaque like with a toothbrush seems to put a lot of microbes into the air. So there's things that we can do about all of this, but in particular, it does seem like just being minimal in terms of how much we agitate the plaque can really serve us well to minimize the microbes that are put into the air. And so they went further and sort of standardized their analysis of how long this stuff might stay in the air. And so I'm sure a lot of folks have seen that aerosols can stay in the air for 30 minutes, 3 hours. This has been demonstrated with SARS-CoV-2, the virus that causes COVID-19. And so what you see in the right column at bottom here is the median particle diameter. So that means that the average size of the particles that are in the air. And basically, the smaller the particle is, there's sort of this, the smaller the particle is, the longer it hangs out in the air. But what you can see in the middle column is that after an hour, there's 5 times less particles. After 4 hours, there's 10 times less particles, and so on, without any treatment to the area. There's just the particles precipitate out with time. But that there is this smaller size of particle that does correspond to little chunks of a handful of viruses together that can stay in the air for a long time. So that's why we need to take extra precautions to deal with that. And so the procedures that we were looking at earlier, examination and scaling, there were no particles that were that smaller size that seems to hang out a lot, which is great, but brushing their teeth is. So there's a whole lot of recommendations that can follow this, and that's not the focus of today, but I did want to share that the aerosols are there, that doing prophies and drying teeth and brushing the teeth all produce quite a bit of aerosols that are of the size that could be concerning as we move forward. And just examination and scaling doesn't seem to produce very much. So the other thing is that there actually were sophisticated studies, and so many sophisticated studies using different techniques of either comparing healthcare workers that treated patients with SARS-CoV-1 to before and after, so the same types of healthcare workers before and after, or healthcare workers during the SARS-CoV-1 outbreak that did the same types of procedures, so in parallel or at different times, comparing the risk of the healthcare worker, us, getting infected with SARS-CoV-1. And the reason that I'm focusing on SARS-CoV-1 is that the viruses are extremely similar. There's certainly important differences in the presentation of how long it takes from when you get infected until you look sick. There's important differences that are affecting the way that it is spreading around the world. But in terms of the virus's behavior and its ability to infect us, the route of infection, it is remarkably similar. And so I think we can learn from it. And in particular, there's all this work from people who were doing airway stuff in the hospital where patients were active with their SARS-CoV-1, their SARS disease. And so in particular, there's an increased risk, so 6 times higher risk for healthcare workers to get infected with this based on doing tracheal intubation, so sticking a tube down the trachea into the lungs, and doing ventilations, doing tracheotomies, and doing manual ventilations. So what this means is these are all procedures that generate aerosols. And if you look to the bottom of the page, all of these procedures were studied and there was no increased risk of the healthcare workers that were performing them getting infected with the previous SARS coronavirus. And if you look at them, there's a lot of stuff that we do in dentistry regularly. So they were doing high flow and normal oxygen masks. So that's very analogous to putting on a nitrous mask. They were doing chest compressions. They were doing nasogastric tubes. They're collecting spit. So there's quite a few procedures that are kind of analogous to what we do, but the ones that seem to increase the risk that they would get disease are really about creating aerosols. So word to the wise. And then just the last piece for my public service announcements is don't forget the goggles. There's been a paper specifically about in one of the most esteemed journals in the world saying don't forget the goggles in the Lancet last month. And this was studied and pretty well demonstrated that SARS-CoV-1 could infect through the eyes. So our face shields are not enough, our goggles, our glasses are not enough. You really need goggles. And I am planning on using my swimming goggles when I go back to work or when I go in for urgencies. And we'll all figure it out together, but protect your eyes is the other announcement. Okay, enough of the COVID stuff. On to the real dentistry. So, of course, this is particularly relevant in this time because non-restorative treatments don't produce much aerosol. But if you haven't seen it, and I think most dentists, most assistants, most hygienists, most dental personnel across the world have not seen this, but 2 years ago, the American Dental Association came out with a landmark study, a landmark guidelines, evidence-based guidelines and report, published 2 simultaneous papers. And quotes from this are clinicians are encouraged to prioritize the use of non-restorative treatments based on effectiveness, safety, and feasibility. I had never seen the term non-restorative treatment before, and I'm guessing most of you haven't either. And so what this is it means treating a cavity without putting in a filling. So for the American Dental Association to come out and suggest that we prioritize this is pretty solid evidence that there is enough evidence that we should be doing this more. And the next paper said silver fluoride put on twice per year is effective for treating, for stopping, arresting advanced cavitated carious lesions on any coronal surface with moderate to high certainty. So moderate to high certainty means we don't need more studies. We have enough information that we can just go ahead and use this as the standard of care. They're not defining the standard of care, but if the ADA is saying it, it already is. And so that should just demonstrate that this is not a fringe idea. This is already well established. And so in these papers, they specifically call out that if there's not a hole in the tooth, if there is demineralization, which in general is radiographically in an X-ray, that a cavity would go as far down as the DEJ and even into the first third of the dentin. It is not cavitated in the vast majority of cases. So in those cases, you can use, there's high levels of evidence that you can just use fluoride varnish, that you can use a fluoride gel, that acidulated APF gel, or a high strength fluoride toothpaste, a prescription strength fluoride toothpaste. And once you have a cavitation, once you have a hole, that you can use silver fluoride. So this is really the parts list. So it's all about the fluorides. And so adding the silver into it and bumping up the strength of fluoride really gets you to be able to treat the holes in teeth just with a liquid brush that's applied by a provider. So that said, in this world right now, where we're not seeing patients unless they have a serious urgency, how do we get these products to patients? And so I wanted to turn all of you on to an amazing resource that's been around for a few years called New Enamel. And so this really brilliant idea is that it uses a website algorithm, simple question answer setup to do a caries risk assessment using the UCSF Canberra survey through teledentistry, and it generates a prescription, personalized instructions, and then it sends these products, exactly the same ones that the ADA recommended as treatment for non-cavitated cavities, fluoride varnish and prescription strength fluoride toothpaste, depending on the risk assessment. And it gives personalized instructions for brushing and all of that kind of stuff. So I think this is a huge resource for right now when we really can't see our patients and we want to provide care. For any patient that you think might be moderate to high risk, this will get them access to the products that they need. Of course, you can also prescribe it to them by teledentistry over the phone and send it to them yourself or have them go into a pharmacy. But this is a robust setup that I've been very impressed by. I think it's underutilized. So now's the time. The next thing I wanted to share is that in terms of how to stratify, how to approach each tooth, each patient, and translate what you see into the use of these non-restorative treatments and some of the other minimally invasive treatments. This is something we went over in my last webinar that will be available this coming Wednesday, we think, on the Elevate Oral Care CE website. But this is an algorithm that we really went through the rationale behind this. And the idea is that if there's a caries lesion, if it's not cavitated, you can use non-restorative therapies. If it is cavitated, then the next question becomes, is it cleansable? Can a toothbrush go in there and really clean it out? Can the flow of saliva really clean it out? And if yes, non-restorative therapies will work the vast majority of the time. If not, so if there's a food trap, if it's really sequestering food and plaque, if a toothbrush cannot get in there, if the saliva cannot flow through, then we want to go to our more advanced techniques of sealing the lesion, maybe combining with the non-restorative therapies and sealing the lesion either with a glass ionomer sealant, resin sealant if you want to, Hall crown, depending on the accessibility and all of that. And a lot of this is really detailed in a book that came out at the end of last year that we're really excited about, called Smart Oral Health. So this really compiled the last 15 years of experience of using silver fluoride and non-invasive glass ionomer, techniques, and many other minimally invasive, maximally effective medical management of caries into one cohesive text, sort of an overview from lots of different clinicians and scientists, and that is available on Amazon. So pardon me, sorry for the product plugs, but I think that it's useful, particularly in this time. Pardon me. So with that said, hopefully that gives a framework for that the ADA has blessed using silver fluoride to treat cavities. And that my perspective is that, as we went over in the algorithm, if there is a cavity that is not cavitated, if there is a cavity that is cleansable, silver fluoride will work the vast majority of the time. If it's not cleansable and not accessible, we kind of need more combinations of things. So basics of silver fluoride, what is it? If you haven't heard of it before, if you haven't used it before, you're not familiar, this is a product that is celebrating its 50th anniversary of being cleared by the Japanese government for use. It's been used in millions of patients over the years in Japan. It has silver, ammonia, and fluoride in water. In broad strokes, the silver kills bacteria, but at this high concentration, all three of these ingredients kill bacteria. No, Jeanette McLean, that is not a dry cough. I'm healthy, thank goodness. But anyway, the silver really it strengthens the infected dentin and the affected dentin, and the fluoride strengthens the affected enamel and the affected dentin. So it remineralizes and strengthens and kills bacteria. So it's this beautiful combination of these two products, the silver and the fluoride, working together to control the bacteria and strengthen the tooth. We use very small amounts, which is what makes it so safe. And so what does it do? It stops cavities. That's what arrests means. So this literally is treating a cavity without putting in a filling. It prevents cavities. We'll talk about that in a little bit. It decreases hypersensitivity. So just like fluoride varnish, it's cleared by the FDA for decreasing sensitivity of teeth. So if you have an exposed root that's sensitive to water, sensitive to air, sensitive to cold, sensitive to hot, this is an extremely effective therapy for that sensitivity. And any areas that are carious, that have a cavity going on, or that were underdeveloped, will turn black. And so those are the actions. How do you use it? So typically, we dry, we apply, and we say bye. But in particular, you try to isolate with cotton. You do not need a rubber dam. You don't need anything fancy. And you get the caries lesion as dry as you can. You put it on with a little micro brush. Some people believe in agitating the cavity to get the silver fluoride to flow in more, and then you protect that reaction for at least a minute. And so if a patient has the cooperative skills to just stay open for a minute, then they just stay open for a minute. And if you deal with 1-year-olds, 2-year-olds, 3-year-olds like we do, special needs folks, then it really makes a lot of sense to just cover with a varnish or a Vaseline over that. But in the modern world, we are not going to air dry, because as we saw, that produces as much, actually a little more, microbial aerosol than coughing. And we're probably not going to agitate with a microbrush. We're just going to apply gently, just put it directly on the area and let it soak in. And so that's the COVID protocol, just dry with cotton and apply with a brush, and then protect the area with a varnish, Vaseline, or thyme. So here is a video. Okay, so that is the focus simple protocol. You access the area, isolate with cotton. You can see there's a cotton roll there. If this was a squirmy 2-year-old, I would have the cotton on the other side to minimize the contact with the tongue and maximize the happiness of the patient, because this stuff tastes pretty funny. And you see the protocol. So this was done before Advantage Arrest had a blue tint. But so one of the options for silver fluoride now has a blue tint in the US and some other countries. I'm sorry about that. This is the tray setup. So, pardon me, a little Vaseline to protect the lips. This stuff will stain the skin. Little cotton applicators to put the Vaseline on, a micro brush to put the silver fluoride on, a plastic dappen dish, cotton isolation. This is all you need. Since this is all you need, you can imagine doing this just about anywhere. I have done silver fluoride treatments anywhere you can imagine. I've done it in living rooms. I've done it outside on the bench. I did it at my dining room table a couple weeks ago before this social distancing started. One of my friends asked about it. We did it. It was easy. I've done it in airport terminals, but you don't need to be in a dental operatory to do this. And so amidst the coronavirus outbreak, I think it makes sense to think about not trapping yourself in an enclosed environment where all of the aerosols are going to stay. And if you can see patients outside, maybe in the car with their windows down or on a park bench or whatever, you can bring this kit anywhere and do some basic, treatment of painful cavities or caries control going forward. So mechanisms, how does this stuff work? Wait, you're telling me that you can treat with that little liquid that's going to treat a cavity? How does this work? So this is a beautiful rendering of what a cavity looks like in a microscope. So those are your dentinal tubules filled with strep mutans and friends. Going down from the top is the outside of the cavity going down towards the pulp. And in particular, what you see is there's just more bacteria and less healthy tooth structure at the top, at the outside. And as you go down, there's less and less bacteria, but the bacteria grow from within, the cavity grows from within the dentinal tubules. So the outside areas are the most broken down part, where there's the least mineral, the most exposed protein, the most bacteria. So there's been beautiful studies such as this one, where they take dentin, a slice of dentin, and they put it in strep mutan soup. They just add a bunch of strep mutans, a bunch of sugar, a bunch of chicken broth, like stuff, and let the bacteria grow into the dentin for a week. Take it out and put a green dye on all the living bacteria, a red dye on all the dead bacteria. And so you can see, indeed, the bacteria grow down into the dentinal tubules and they overwhelm the outside area. And then they rinse off just gently, dry gently, put some silver fluoride on, let it sit for a minute, rinse gently, and put it back into the strep mutan soup for another week. And after sitting there for a whole week, the red is dead, the green is alive. And so you see on the right that the silver fluoride has gone in and killed all the bacteria that were deep down into the dentin, and that it actually eventually, in strep mutan soups 24/7 loaded with sugar, the bacteria can start growing in from the top again, but they do so much more slowly. So you've made the tooth much more resistant to bacteria growing into there. And so what we've seen is that outermost area, if it's so broken down that it's mainly just protein and bacteria and there's very little mineral left, that condenses down, as you'll see in the next slide. So same orientation, this is a real cavity, a permanent tooth, where the lesion was very much into the dentin. And so the infected dentin condensed down into this really solid, dense layer on the top. I think it kind of looks like a magic carpet, like Aladdin's magic carpet. But it's this really dense layer of silver, fluoride, dead bacteria that are encased in silver, and the exposed dentin proteins that were there. And then beyond that, you get these solid silver wires that really end up working like rebar in cement, filling in the dentinal tubules that the bacteria were parading through before, closing them up and actually strengthening the tooth. So it seems to chase bacteria down, kills most of them, and then it condenses that really the weakest, stickiest, nastiest part of a cavity down into something that's at least twice as hard as healthy dentin. And it reinforces the less weakened part, the affected dentin, with these wires that go through. So it really does a lot of jobs all at once. These things take some time. And so based on the studies that we've been doing of how long it takes, I would recommend to wait at least 3 days, if not a week, between treatments if you're going to do multiple treatments. And in terms of how this works, a lot of that was focusing on the silver, presumably, what you're seeing here is the silver, but don't forget about the fluoride. So this is the tooth of a little girl with a beautiful story of having her cavities controlled by silver fluoride. And then when she was about to start kindergarten, entering that phase where kids start making fun of each other because of their looks, Dr. John Fricella followed up Dr. Steve Duffin's work in putting a little glass ionomer opaquer over the black area. But the point of showing you this slide is that on the top right, that pink fuchsia red area is extra dense. And that extra density is actually fluoroapatite. And so a huge part of why this kiddo was able to have her cavities stopped by silver fluoride was the fluoride itself. We have all this focus on silver because it turns black, as you can see there, where I chipped off the opaquer because the tooth had fallen out. But a huge part of this is the fluoride. And so what you see at the top right is in that fuchsia red is fluoride rather than the silver. So just don't forget that fluoride works and makes the tooth more resilient to cavities and makes the tooth a little harder too. And so this is a slide, we're not going to go through these studies, but this is a slide just to say that, we know fluoride prevents cavities. This material has twice as much fluoride as any other, as fluoride varnish, for example. And the silver seems to help. So that it turns out that this also prevents cavities. So this is our summary of the clinical trials and clinical studies on using silver fluoride versus a control, either a placebo or a no treatment control, to prevent cavities. And in summary, putting it on once per year gives you 60% less cavities than if you didn't do anything at all. So for comparison, fluoride varnish, if you put it on 4 times per year, gives you about 37% prevention. So going forward, this is extremely simple. It minimizes the number of contacts you have to have with the patient or the patient has to have with you. It works. If there's no cavity, there's no stain. So this is an extremely effective tool for preventing cavities as well. So, okay, so that's the mechanisms, now some safety stuff. And this is kind of fun. So we have a question of how much fluoride is in there. You just told me it was twice the strength of fluoride varnish. So doesn't that mean that there's a lot of fluoride? Well, it turns out the volume we use is so small. You saw what I used. I used the micro brush. I think I dipped it twice to treat 3 teeth. The volume is very tiny. And because it's such a small volume, the total amount of fluoride is actually very small. And so the amount of fluoride in a whole drop of silver fluoride from an Advantage product, from the Elevate product, Advantage Arrest, is this metered drop, is the same as if you took some fluoridated tap water and you have the 2 liter of that. And so the way that I discuss it with patients is I say, okay, you have a 2 liter of tap water, a fluoridated tap water. You condense all that fluoride down and put it into the teeth where we want it the most, instead of putting it all throughout the system. How would you feel about that? And so in comparing to a packet of fluoride varnish, you have to have 6 drops of silver fluoride to get as much fluoride as in 1 packet of fluoride varnish. So in other words, there's 6 times more fluoride in a packet of fluoride varnish than there is in a drop of silver fluoride. So that helps to frame things for a lot of folks. I hope that's helpful to you. And that there's actually been sophisticated studies. This was published in the American Dental Association journal last year, looking at how much fluoride is in the blood in adults after you put silver fluoride on a few of their teeth. And there is no measurable increase in fluoride in the blood because we're really just putting it into the teeth and it absorbs very well into Caries lesions and into the high risk surfaces of the teeth. So the other thing that people ask me about quite a bit in terms of safety issues is what about the pulp? And so people keep telling me that, there's no studies of the pulp. There are studies of the pulp. So here's one of them. There's been beautiful work, actually mainly from India, where they've taken premolars that are going to be removed for orthodontic purposes. They've drilled deep holes where they're like 0.5 millimeter or less from the pulp and treated with silver fluoride or calcium hydroxide or glass ionomer or nothing, and looked at the differences in inflammation or tertiary dentin formation 6 weeks or so later after they take them out like they were going to do anyway. And really, it's no more challenging than sealing up with a glass ionomer or calcium hydroxide. You get tertiary dentin formation. You know, histologically, the pulp looks fine. There's no big deal. And this was shown clinically with human cases as well for silver nitrate back when they were using that a lot more in the 30s, 40s, and 50s. So really, it seems to be surprising how well tolerated this stuff is in the pulp. And so sure, if there's a cavity that's very deep, we put silver fluoride on, is there a chance that it's going to abscess? Of course. What we've seen from using this material for over 5 years now is that it just seems like sometimes you're too late and that the cavity was already going to abscess. It was already going to become irreversible pulpitis. And so that's where the clinical skills come in and deciding, are we going to take that chance that we're too late? Well, what else are we going to do? Is there something more definitive, more successful that we could do, like just take the tooth out? You know, that's what lies in the hands of the clinicians. But very frequently, I will see a deep cavity where I'm reasonably certain that there's some thin layer of dentin between the extent of the cavity and the pulp, and I will put silver fluoride on and have the patient back a few weeks later. And if the tooth abscessed anyway, if they got there too late, you know, it ends up being months later, then we do what we need to do. And if not, then we just seal over the area or keep putting silver fluoride on. So there doesn't seem to be any dramatic effect on the pulp as compared to these other materials. Okay, so this is also sort of a public service announcement. There's a wonderful product from another company called Rivastar. It's from SDI. It's been used in Australia for almost 20 years. It works. It is a higher pH. It's pH 13. That is like Drano. That is like the stuff that you use to clean out your drains. That is a very high pH compared to pH 10 for all the other products available around the world. And so that means that the safety is a consideration. The head of sales for North America for this company looked me in the eye and said that this product should only be used under rubber dam isolation or when you have a formal gingival barrier. So this product is a great cavity liner. This product is a great indirect pulp cap. But for where silver fluoride is typically used, at least in this country, where you are going in and very simply and quickly treating a cavity without putting in a filling, this product can create burns. There are claims about not staining. When you can see top versus bottom is using this product, it still stains. And so because of the pH, you can get chemical burns. So you really need either rubber dam or a gingival barrier with some good isolation to use this product, and it definitely works. But just the high pH is a concern, and the claim of no stain is not based on anything in real life. Just a quick plug for something that I'm developing is something called D-stain. Silver fluoride does stain demineralized areas, and we have something that topically, without removing tooth structure, can remove those stains. So we're excited about that to come in the future. We have consent documentation forms. These were developed by us at UCSF. We have 5 languages. Use the website at the bottom. This is a documentation of the consent process. So we usually consent by conversation. If you want to have a signature, go for it. There's lots of pictures available on this presentation through lots of websites that you can use before and after showing the stain. I highly recommend you show the stain to folks before and after before they make their decision. And these consent forms you can download as Word documents and use however you please. So evidence and frequency. So we're going to go through some data a little bit quickly, but the idea is to show you that we've been really thoughtful and that you can have your own decisions about how to make a frequency protocol, how frequently to put on this medicine. And so the idea here is that this is a medicine. Silver fluoride is a medicine. It's not a one time and then monitor. You keep putting this on over time and monitor the response as well. So the suggested frequency protocol for what I call mild caries, you have active cavities. It doesn't wake you up at night worrying about whether they're going to grow or not and get in the pulp within a month or two. It's just to put this stuff on every 6 months. If it's not cavitated, if it's in cleansable areas, this works extremely well. If you have more moderate caries, what I would call, it's an unofficial term, but you just have more disease activity. Maybe the patient has, 8 cavities throughout their mouth, 4 cavities throughout their mouth, and you want to do more, just add what I would call a loading dose. So the analogy here is to folks who have a facial infection, facial cellulitis from a tooth. You don't just have them start on 3 times a day, every 8 hours antibiotics. If you have a concerning infection, you're going to have them take a loading dose. You're going to have to take a double dose. And if it's really concerning, you're going to maybe go in there and start IV antibiotics, or you'll incise and drain and then start IV antibiotics. So the more ferocious the infection is, the more times you're going to put the silver fluoride on at the beginning of therapy. But once you get the infection under control, you need your maintenance doses. You need to keep putting it on every 6 months. And so really that's what this is all about. If you look at the schematic at the top, you see that no matter how bad the cavities are, really it just ends up changing how frequently you put it on during that first 6 months, is what we've learned over time and from the data. So this is, there's a whole presentation on YouTube that you can look at that we've done where we march through the gory details of each of these studies. But just to show you that there's been 7 clinical trials in kids alone. There's studies in adults looking at this. There's clinical experience in adults, but these are just 7 studies just in kids in primary and permanent teeth, where there's hundreds. This is 370 kids, 180 kids, 840 kids. They're big studies, really well conducted, randomized clinical trials where each patient gets a different treatment. And the red is silver fluoride twice a year. The black is silver fluoride once a year. And we're looking over time. So this is just to say we have a lot of really high quality data, as the American Dental Association agreed with and said go forth and prosper. So just to outline what we do with this information, there was a really careful study looking at what happens if you take out the infected dentin beforehand. That's the black versus the orange. And there was no difference. So you don't need to scoop out any cavity at all. And so in this time of COVID-19, you could have the patient brush really well the night before coming in. You can have the patient brush very well again before they come in at home, so they don't give you all their microbial aerosols. And then you just put the silver fluoride on. You don't need to excavate or anything. There's no long-term benefit at all. Another study, 3 studies have looked at frequency protocol. So this is looking at twice a year versus once per year versus once and never again. And what you see in the bottom is that if you put it on once and never again, you lose your effect. You get an effect after 6 months and then it goes away. If you keep putting it on over time, more and more cavities will become arrested. So just like you have an infection, you need to wait until the 3rd or 4th day to see that this disease has resolved, that the infection has resolved, after taking antibiotics before switching antibiotics or switching treatment. So in dentistry, this is crazy because if you look at the timeline, that's like a year and a half before you get kind of to the maximum effect, maybe even 2 years. So you keep putting this stuff on, it keeps working over time, and it really takes time for things to change, which is new to us, to say the least. Last study, this was using a material that, it's a long story, but basically it was a 9% material, and they looked at having multiple applications early on, that's the brown, versus just doing it once a year, that's the gray. So 3 times and then never again is the brown, and just once a year is the gray. And what seems to be the most important is these maintenance doses. So the gray stays higher than the others after years, but the initial extra applications can help. So we combine this for our patients. So the cavities are really bad, we put it on multiple times in that first 6 months, depending on how bad things are. And if they're really not that bad, then we just focus on, and regardless, we focus on the maintenance doses. So what to watch for? And so what I've learned from doing this since about 2013 is that really the key time to evaluate your success or failure of this therapy per tooth is at 6 months. And what we see is that about, give or take, 20% of cavities, if you just do that every 6 months, 20% of cavities will keep growing. And at 6 months, if it's gotten bigger, you need to do something else. You need to add something else to the treatment regimen. If the cavity is arrested, and about 45% of them just doing it twice a year will be arrested at 6 months, you can slow down to once a year just to maintain that effect. But for the ones that are still active but have not grown, if you just stay course, those will stop over time. And that's borne out in the clinical trial data, where after 6 months, you see this is about 45% of them have stopped. But at 18 months, you get a higher number. So those 45% will stay stopped if you just keep putting silver fluoride on. But there's this 35+%, maybe 50% plus, that if you just stay the course, they will stop with time. And those, as what we've observed, that those are the ones that did not grow, but still looked like they were active at 6 months. So just stay the course, keep putting them on. Unless it grows, then do something more. That is my frequency protocol. Use it as you please. And this is something from Graham Craig, who's been doing this for about 40 years in Australia, really a mentor to lots of us. And he has a beautiful book on Dental Outlook, guiding folks through this. And so these are pictures from his book. And so what he's looking at is cleansibility, cleansable. This is a concept that we went through last time, something G.V. Black talked a lot about. And so if you have a food trap that's collecting plaque, where the saliva doesn't flow, where the toothbrush can't go, that is the least likely to stop. Same thing of contacts between the posterior teeth. In particular, the contact between baby teeth is very broad. Between permanent teeth, between the molars, it's very broad. Between the premolars, it's not, with exceptions that you guys know about, like the lower second premolar to first molar contact is pretty broad. So those are the least likely to stop, in particular if they're cavitated and you can't get in there with a brush. The smaller contacts are most likely to stop, and the more accessible areas are also most likely to stop. So let that be a guide, is the cleansibility. Just to look at some x-rays real quick, there were some lesions between the canine and first primary molar here that are, non-cavitated, and here at the top on both sides, and just silver fluoride every 6 months. It just never grew. It almost looked like it disappeared. And so that's where an area that the contact is very small, looks like it actually opened up with time. And so some of the cavity actually even disappeared without turning black in this patient. So that was a success. Where we monitored, nothing changed. That's what we like to see. This patient, the cavities got bigger. And so this was an area where there was a small opening to a moderate sized cavity. We tried silver fluoride, the cavities got a lot bigger. We needed to do something else. And for this kiddo, all of the areas that were marked with that green and black are the ones that grew. There were areas that were not marked are the ones that didn't grow. So if we had more time to go through this, you'd see that there's quite a few cavities that kind of look the same left to right, and one grew, one didn't. It's really kind of hard to predict. But what I'd say is that these cavities between the back teeth that are not accessible to a toothbrush are the least likely to stop with silver fluoride only, and that's where we often need to combine with other therapies, but sometimes it does work. And if it's not cavitated, so you see there's some kind of larger cavities that they look like larger cavities initially, but they're really just in the first third of dentin, and those were the ones that did not grow over time. And so if it's in the first third of dentin, it's probably not cavitated. It's probably going to work extremely well. Okay, so that's how we follow, that's how we monitor, that's how we go. Now, just very briefly, Jeanette McLean talked about this beautifully in her webinar. We'll talk about this more in future webinars, but just in broad strokes for restorations, we're going to go through just a couple details. We get asked about bond strength very frequently. And so was recently a meta-analysis, which is looking at a bunch of different studies. So there's so many studies, we can combine the results and look at the effects over all the different studies done in all the different laboratories around the world. And there is no effect of silver fluoride on bonding for glass ionomer. For resin, there's this effect unless you rinse afterwards. So it's kind of like there's no effect. as long as you put the silver fluoride on, wait at least a minute for it to soak in, and then go through your normal bonding procedure for your resins. And so, of course, the bonding procedure involves desiccating the tooth. So during this, COVID-19 time, it probably does not make sense to use a lot of resin that requires you to dry and put aerosol into the air, unless you have a rubber dam and antiseptic and all the, all this stuff. And so I'd recommend using a glass ionomer. But bottom line is, it doesn't affect the bonding unless you put the silver fluoride in the middle of your resin bonding procedure. Then it can affect the bond strength. So just don't do that. Stain, silver stains, silver fluoride stains. So restorations that are placed the same time as the silver fluoride treatment can stain. If there's any resin, it's going to turn all black. If it's pure glass ionomer, depending on the formulation of the glass ionomer, it's probably just going to stain around the margins, as you see in the middle there. When the patient leaves, it's nice and white, and they come back, you have this ring around the rosy. Maybe that's too soon given the current circumstances. If you just wait a week for it to set in, then you can cover it up and it won't stain the material. So there's just going to be a couple examples here. Dr. McLean showed this in her webinar. The same case is that if you can extend your opaque glass ionomer, your high viscosity glass ionomer, beyond the cavus surface margin, beyond the margin of the cavity, you don't need to excavate. I should change the slide. Sorry, there's no excavation. I was wrong. But this is where she put silver fluoride on. She waited at least a week for that response to happen, for the cavity to harden and the stain to set, and then just covered it up with a glass ionomer. Here's a slightly larger cavity where we did exactly the same thing with no excavation whatsoever. And so literally what we did was we put silver fluoride on, sent the patient home, brought the patient back, cotton isolation, a little conditioner, used a moist 2x2 to get rid of the bulk of conditioner, used a dry 2x2 to just remove the pooled liquid, and then we put a glass ionomer right over the top and protected that glass ionomer with Vaseline for the next couple minutes, had the patient bite down and chew. And we did sealants, as you can see, at the same time on the other teeth. And so this is the technique. It's very complicated. This is Dr. Duffin. Very sophisticated. And then the most important part is really removing excess and adapting the occlusion within the first minute after the mix. All right, so we just adjusted the occlusion and that was it. So as long as the patient can bite down, so what you didn't see is that Dr. Duffin had some Vaseline on his glove that the glass ionomer was put onto. Dr. McLean talked about that, but that is as simple as these things can be. So setting these up into multiple visits can really work. The glass ionomer makes it so that you don't need to spray water. The silver fluoride makes it so you don't need to spray water. All of that keeps us safe during this time. So very briefly, take homes. If you use it at least once a year, you get about 81% of cavities stopping. The more frequently you use it, the better the effect. Prevents about 60% of new cavities from forming. It is the most effective preventive that we can do on teeth. Drying before use was one of our take homes. We're not going to be able to bone dry to desiccate a tooth in these days. All of the clinical studies were done out in the field, at nursing homes, at schools, and it worked just fine without complete desiccation. But that probably means that we're going to have to repeat application more times if we're not drying as well as we could. It's extremely safe, lots of safety studies, and it stains the crap out of everything. So be careful. So with that said, I would like to thank everybody for your time. We have a more in-depth video of how to at this website. I will post everything by the end of the day. You can use these slides, some material. I will post my recommendation of a paragraph of like a first introductory sentence, and then information for patients. My email's right there. You guys can please contact me with ideas, questions, discussion about how to move this all forward. Again, I appreciate your time. And I wanted to say that we'll be doing more of these webinars into more topics. Please contact Elevate with suggestions. And thank you.
All right, Dr. Horst, thank you. That was a wonderful presentation, and thank you all for joining in. I'm just going to go over a couple of things real quick, and then we will jump into some questions with Dr. Horst here. So just a reminder for the CE certificates, those will automatically be emailed out to the email that you provided in about an hour or two from now. And don't forget to check your spam folders if you're not seeing that. And then be sure to join our live webinars that we have coming up next week. We're planning on an exciting panel with a lot of the speakers that you guys have heard so far. Dr. Horst will be back, Dr. Matthew Allen, Dr. McLean, and Dr. Glassman will all be back next week, and we'll be updating our social media. So be sure to like and follow Elevate Oral Care on both Facebook and Instagram to keep up to date on any upcoming programs that we will have in the future. And then that will also provide you with the information on how to register for those upcoming courses as well. And if you guys need any assistance with anything, feel free to also reach out to our customer service, which the number for that is 877-866-9113. So thank you guys all again. And Dr. Horst, we're going to jump into some questions here.
Right on.
All right, so we had quite a few questions coming in regarding a CDT code. So is there a CDT code for the use of silver diamine fluoride?
1354-1354. So that is Caries arrest without removing healthy tooth structure. That is per tooth, and that has been around for 4 years now. So that a lot of insurers are covering that. If you're using it for prevention, there's whispers on the street that there might be a new CDT code specific for silver fluoride for prevention. But for now, 1208 is topical fluoride for prevention. So 1206 is fluoride varnish, and 1208 is any other fluoride. That's what we've been using.
All right, great. And speaking of prevention, quite a few questions came in on that as well. Can you kind of explain when and where to apply silver diamine fluoride for primary prevention?
Fantastic question. Thank you. I was hoping somebody might ask me that. So what we do for using silver fluoride for prevention is really targeting the highest risk surfaces. So in an older adult, as root surfaces are exposed, obviously there's no enamel on those areas, so they're much more susceptible to caries, hard to clean. So we put silver fluoride on exposed root surfaces. In partially erupted third molars that are hard for a patient to clean, we put silver fluoride in those occlusal and buccal areas. For 1-year-olds whose older siblings are missing their front teeth because their nursing caries, their early childhood caries, was so severe that it wasn't able to be controlled, that's where we put silver fluoride. It's on the anterior teeth that we know are going to be a problem for this kid. So we don't slop it all around like a lot of folks do for fluoride varnish. This stuff is intense. It doesn't taste great, and so you do want to carefully dry and apply, targeting the highest risk areas. For me, for the typical adult or teenager, this is the posterior interproximals. And so we isolate by quadrant with cotton. We dry as well as we reasonably can interproximally, and then we put it on. I dab it on at the embrasures and watch it flow. Thanks that the Elevate product now has a dye, and we can actually see it flow into the contact area. And the other procedure, especially that I'm going to be doing now that we can't use an air blast into the interproximal areas, is to use unwaxed floss and put it into the contact area, and then put the silver fluoride on, and then pull that area into the contact. So just focusing this on the highest risk areas for that particular patient.
All right, great. Let's see here. We had a lot of questions asking that came in. I know you discussed it a little bit, but about using this for root sensitivity as well.
Yeah, I mean that's what the FDA clearance is for basically all fluoride products, except for just normal fluoride toothpaste. Fluoride blocks dentinal tubules, and therefore decreases the sensitivity. It's been well documented. It works great. A number of clinicians that I know very well have used it on themselves to treat the sensitivity. It just works. I think with the combination of the silver creates some precipitates there as well. It doesn't stain if there's no cavity there. So that's just simple, dry and apply. And so just like you would use Gluma, this works really well. You just want to, have the patient know that if there's a restoration nearby, if there's an open margin that you're uncertain about, cover that area with some varnish or some Vaseline first. Be careful. It can stain areas that, where you have leakage. It can stain caries, but if there's no caries, there's no leakage, go forth and prosper. It works really well. And I think that's a 9910 is the desensitization code, 9910.
All right, great. This question came in and says, would you use SDF on an at-risk 6-year molar still flapped if a sealant is not possible? And if so, what is that technique?
Oh, 100%. That's a great technique for it. So that was one of our original indications. So when I was at UCSF, we had a whole panel of the dean and department chairman and clinical heads that got together and looked at this and saw, oh my God, there's so many high quality clinical trials. We need to get this out and start using this in the school, throughout the school. And so one of the first indications that we thought of was just hard to treat cavities and hard to prevent areas where sealants are hard to place that you would normally want to. So totally. So same thing, you dry and apply. So if there's a partially erupted third molar, a partially erupted first molar, whatever tooth, that area, the operculum, the gum, can sit over that area and create a food trap in an underdeveloped tooth. That is going to create a big cavity very quickly. So what you do is just, to the best of your ability, isolate the area with cotton and dry as reasonably as you can. And usually for me, that's just taking a cotton roll and kind of pushing gently into the gum area and then placing the silver fluoride just underneath. I haven't experienced it stinging anyone unless there was, moderate to severe gingivitis going on there where, you touch it, it bleeds. And even if there's inflammation, like mild gingivitis without significant bleeding, I haven't seen it hurt. I haven't seen it sting. So yeah, you just put the microbrush in the area and let it soak in for a minute.
All right, great. Someone's asking, what specifically does SMART stand for?
Silver modified atraumatic restorative treatment. So for 40 years now, 30 years, 35 years, the World Health Organization has been recommending atraumatic restorative treatment as the primary means of controlling cavities in primary teeth. So in the States, the AAPD, who I know and love, calls this interim restorative therapy or interim therapeutic restorations. It's a scoop and fill glass ionomer. And so it's atraumatic in the sense that you don't need to numb the patient. And that was really pioneered by Jo Franken. And so what he and many others, in particular, I think Graham Craig was the first one to realize this, is that if you can combine the chemical treatment, the pharmacological treatment of cavities with silver fluoride, with reduced excavation, reduced taking out the cavity, and then using a therapeutic restoration. So you kind of have this minimal caries removal. You treat the cavity with silver fluoride, and then you seal up with an active restoration glass ionomer that's going to make the tooth stronger. It's a wonderful combination. So you modify the traditional ART technique by just putting in silver fluoride. And so there's really kind of two ways to do that. One is with excavation. So you just do it all in one step, all in one day, where you excavate, then you put in silver fluoride, and then you put in the glass ionomer, or you do your initial excavation, then you put in the silver fluoride, and then you excavate a little more, and then you put in the glass ionomer. But you're going to expect some stain unless you really are comfortable and you've done this a bit, then maybe you can avoid the stain. Or you do what I showed from Jeanette McLean and myself, that I've been doing since 2014, is you put the silver fluoride on when you see the cavities, when you diagnose them. And then at a different day, at least 3 days later, at least a week later, really, you would put the glass ionomer on. And so you use the silver fluoride to reduce the amount of excavation that you need to do. And if there's healthy enamel all the way around the cavity, permanent teeth or primary teeth, you can seal that area with glass ionomer and not have to excavate anything if the lesion is hardened up sufficiently. So that's the SMART technique. Please check out Jeanette McLean's webinar on that material, which again will be available. And oh, I should say this, that art was introduced on World Health Day, April 7th, 1994. So we're coming up on the 26th anniversary as part of the Year of Oral Health. Thank you, Jeanette McLean.
All right, great. You touched on this as well, but some additional questions came in. How can this be applied to recurrent caries and interproximal caries? And just someone said, just to clarify, are interproximal lesions not cleansable areas?
Oh, totally. Yeah. So that's a great question. So to me, the difference of an interproximal area being cleansable or not is whether you have that outer surface of the tooth, the outer surface of the cavity still intact. And so if you have a cavity that shows up on an X-ray and the cavity is to the DEJ or to the first third of the dentin or earlier, chances are extremely strong that the outer surface is still maintained, and what you have is a chemical porosity where the bacteria are not getting into the teeth. And so you can clean that area with floss. Now, there's a lower chance of saliva flowing through that area. There's a lower chance of your patient cleaning it properly, unless they have really meticulous hygiene. So it's more likely that a cavity would grow in that area, but it's very possible to arrest cavities in that area. And Jeanette McLean's study with the Ohio State University, which will be published soon, showed that using silver fluoride in situations like that, where you see it you see a caries lesion that appears to be non-cavitated in the interproximal area, you put silver fluoride on with unwaxed floss, about 85% of those cavities looked exactly the same a year later. So that, to me, that's a sufficient percentage of success to go ahead and do that. Now that number is going to vary depending on your population and how much sugar they're having and all of that. But where things become uncleansable is that if you have a cavitation, an actual hole in the tooth where food is getting trapped and bacteria are in the dentin, penetrating in there, you have an infected dentin, but the marginal ridge is still intact, then that's a non-cleansable area. That's a hard to access area. And so that's sort of the difference to me, is whether there's a hole or not. And so technically, if you had a cavity on the front surface of your upper central incisor, you typically see that down by the gingival margin. If it was into dentin, you would call that a cavitation. But if it was really smooth and you could brush it and keep it clean, that would be cleansable. And so that's a much more cleansable area, much higher success rate. Hopefully that helps. Please follow up by email if this was not sufficient. And I do want to say between questions here that in about 3 minutes, we're going to be joined by my 7-month-old, which is hopefully you will not be too annoyed by, but he's a cutie, and he's our third and the easiest baby I've ever met. So hopefully he'll just add to the conversation.
All right, great. Said you mentioned SDF placement anywhere. What do you recommend for infection control and aerosol protection procedures for the application of silver diamine fluoride?
Fantastic question. So I would recommend that in this time going forward for the next, I don't know, 6 months, 2 years, who knows, to not use the compressed air drying, to not use the rinse afterwards. And those are the two big things, is to not splash the plaque everywhere. I would recommend, in terms of personal protective equipment, goggles and an N95 mask or better. Those have shown to be really effective at preventing aerosols from getting into us. And in terms of what to do with the room, I'm going to leave that for another day. That's a complicated topic. We are diving deep into the literature and again, clinical hospital experience of how to clean a room between patients and what you need to do and how much and all that. But I think, if I had a patient today whose cavities were not responding, who had cavities that were painful, that was so painful that with Advil and Tylenol it wasn't working. And for whatever reason, I decided, we're not going to do a restoration today. That's crazy town. I would have the patient outside, and I would put on an N95 mask and some goggles and put some silver fluoride on there. I would dry with cotton, I would put the silver fluoride on, and I would cover it either with a fluoride varnish or Vaseline. And if the patient tolerated it, which most adults will, most kids will, just the youngest ones, the special needs won't, I would dry with cotton and isolate with cotton, place it, let it settle in for a minute, put it on again once or twice every minute for like 3 minutes. Again, usually we've been air drying. Since we're not doing that, we need to do a little bit more to get the silver fluoride in there to maximize our effectiveness. And so that's what I would do. I would do it outside where any aerosol that's produced is just going to flow with the flow of the wind. And you don't need to worry about the patient coming back into that same space.
All right, great. This one is kind of a two-part here. It says, if a tooth is asymptomatic but radiographically appears to be close to the pulp, is SDF still appropriate? And furthermore, if the tooth is symptomatic, what are the parameters with SDF?
Great question. Thank you. So yes, absolutely, is the answer to the first question. So silver fluoride can be used for any caries lesion where the pulp is not already going into an irreversible pulpitis stage. The amazing clinicians who treat really medical high risk patients have been using silver fluoride for patients with active AIDS in necrotic teeth, or patients who have been treated with IV bisphosphonates in necrotic teeth and with no problems. And sure, there's a long-term treatment plan that this is a part of, but to stabilize the teeth, to decrease the bolus of infection in the teeth, people have been using it in necrotic teeth. So that's an option. It's just when the pulp is exposed and when it's irreversible pulpitis, you don't want to use this material. But if you're looking in a radiograph and you're trying to convince yourself whether it's exposed or not, and meanwhile you can tap on the tooth and there's no symptoms, and the patient, has said, no, it doesn't hurt when I have water or breathe in on a cold day, go forth and prosper. It works.
All right, great. So this one says, just to clarify, resin bond strength is affected after SDF application only when SDF is rinsed. So if SDF is applied and then etch and bond and resin is used, it should be fine? Question?
Correct. That's exactly right. So there've been multiple studies on that. It seems really clear. So self-etch, full etch, there's been lots of different systems studied, and it all has no effect. Props to Dr. Ryan Kwok from Texas for doing a lot of that work.
And then a couple questions still keep coming in about staining. So can you kind of clarify again what you should expect to stain and what will not stain?
Thank you. Yes. Okay, so any hypomineralized or demineralized tooth structure can stain. So what does that mean? So for us in pediatric dentistry land, we see, unfortunately, a lot of 6-year molars, a lot of first permanent molars coming in underdeveloped. We call that molar incisor hypomineralization. And so one of our first lines of treatment now is to treat that with silver fluoride. And what we see is that some areas that are underdeveloped will pick up the stain. It's porous. So the outside of the tooth is very porous, porous enough that it will pick up enough silver that the silver will show when it oxidizes and settles out. Some areas won't. And so same with the carious process. If you have an arrested cavity that's no longer porous, it's stopped, it's just sort of a scar or a stain, a hyper white area that's shiny and smooth, that will not pick up stain. So that's for the tooth stuff, where any porosity in the tooth that's caused by a cavity or underdeveloped tooth structure, enamel or dentin can pick up the black stain. But in terms of other things that you would care about staining, also anything that's porous, like our skin, can pick up the stain. So thankfully that's temporary. And so in chemistry class, we learned that silver nitrate will stain. And so it was a classic thing in inorganic chemistry lab to use silver nitrate to write your name on your arm in this clear liquid. And then, later that night or the next day, it'll show up in black and be there for a couple days. That's a temporary tattoo. So the slower the skin turns over, the longer it stays. So if you have a little kid just on their skin, it'll last 2 days, 3 days. If it's not a whole bunch of silver fluoride on them. If you have an older adult, their skin is turning over much more slowly, so that's going to last longer. It does seem to last longer on lips than it does on the rest of the skin. Countertops that are absorbent can stain, so you want to use a plastic-lined counter protector. And you want to think about if saliva were red, because silver fluoride turns black. So you got to be careful with this stuff. Jeanette McLean has a horde of amazing tricks to get stains out. The go-to for skin is hydrogen peroxide. Another good thing that she taught me that works is makeup remover and nail polish remover for the body. And for countertops, there's a lot of things, but in particular, the ammonia-based cleaners really work very well.
All right, great. This question comes in, says, is it important to wait a full 60 seconds after application before applying the fluoride varnish, especially if you're working with squirmy small children?
Ooh, thank you for that clarification. No, the purpose of the fluoride varnish or Vaseline is so that you don't have to wait that minute. Thank you for asking about that. So the idea there is that you dry as well as you can, you put it on, wait to the count of 5. I count to the count of 10, so that's like 3 seconds, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then I will put the fluoride varnish on. If you want to keep the patient as happy as possible, you put the silver fluoride on, count to 10 for it to soak in, remove the excess with some dry cotton, and then put the fluoride varnish on, and then move on. So the fluoride varnish or the Vaseline is used to protect the area for the silver fluoride to soak in after you let the saliva run over the area. So if you just protect the area for a minute without moving, you can just go on, or you can use the fluoride varnish or Vaseline to move on earlier. Thank you.
As far as immature enamel, do you have to worry about staining? So like when you were talking earlier about the percolated first molars?
You got it. You got it. Yep. You have to worry about staining. If you have an immature enamel or dentin, as in molar incisor hypomineralization, some of that will stain, some won't. Often, even as much of a tooth geek as I am, often I'm surprised by what parts pick up stain and what parts don't. But you want to prepare yourself and the family that any underdeveloped enamel, immature enamel would pick up the stain, and then you kind of see what you get about a week later in terms of the stain. And that can be operatively removed later. You can, I prefer not to remove that hard strengthened enamel and dentin and instead seal over it with a glass ionomer that's going to be opaque enough to mask most of the color. I have some amalgams on my molars. I don't care about the look of them. I don't think people notice it very much. And so a little black spots on the molars, I don't think is a huge deal. But if it is, then might not be the best use, or you might want to treat it operatively later.
All right, great. And then the last little bit of questions that are coming in here, kind of grouping them together, is about Hall crowns and silver diamine fluoride. Can you elaborate just a little bit on that?
It is so encouraging that people are asking about Hall crowns. I want to thank everybody on the IPEDO site in particular for popularizing Hall crowns, and to no small extent, Jeanette McLean and Eyal Simke. Just amazing that I got so excited about Hall crowns back in 2012, I think it was, when I first really learned about them and started doing them, and in 2013 or 14. And when my first child was born, I left Facebook, and then I came back once I headed back into full-time practice, and in just that 3 years, I guess. Hall crowns had gone from, no one have ever heard of them in the pediatric dentistry community to everyone having heard of them, and many people using them routinely. Many people saying, "Oh yeah, we've done hundreds of Hall crowns, thousands of Hall crowns." Pardon me for the noise. And so it works incredibly well. So just to give an analogy that's relevant to the question, when we started talking to Nicola Enos about the Hall crowns and combining them with silver fluoride, and some of the concern that some dental folks in the States were having about sealing infected dentin in without removing it or treating it, we said, well, you could treat the infected dentin with silver fluoride and then put your Hall crown on, so that'll help you sleep at night. Her response, Nicola Enos is the person who's done almost all the research. She's been involved with all the clinical trials, all 4 high quality clinical trials that have been done. She was the one who kind of discovered that this lady, Dr. Hall, had invented this technique and was happily using it for a decade. And so Nicola said, well, how do you beat 99% success? How do you get better than the success that we're already having? And then, a week later came back, why would you even use silver fluoride? Why make it more complicated? And then a week later came back and said, oh, I just did it. So it's already so successful, it's hard to imagine why you would want to do anything else. But because we are still dealing with the enormous paradigm shift of leaving infected dentin in a tooth and just sealing it in, maybe it'll help us all sleep better at night to treat that infected dentin with silver fluoride and then seal it in with the Hall crown. And so that's what we do. We treat with silver fluoride when we see the cavity, and then we have the patient back for a Hall crown later. So kind of when you're putting in the rubber band separator, we put the silver fluoride on at the same time. And then, a week later, we bring the patient back in for the Hall crown. And so it just seems, does it really help clinically? The Hall crown has over 99% success rate. It's hard to imagine how you could make it better. But it does help us sleep at night that we've done something to that infected dentin, and maybe going to reduce the that 1 in 100 case that would fail. So hopefully that helps.
All right, great. And then the last question that came in here is they're asking about the effectiveness of SDF. Is it altered by giving the patient a drink of water after you've applied the SDF?
It's hard to know. That's a good question, and it's hard to know. And that's one of those things that if you look at the data, you can think one thing, and then if you are out practicing caring for patients, you might think another thing. And so looking at the data, there were no special instructions whatsoever from any clinical trial that's been done of one did. But most, the vast majority of the clinical trials, they just put the silver fluoride on and said, okay, go play. Whether the patient was in a nursing home or at school or in a clinic, there were no special instructions except for one study. And that study didn't seem to have a very big difference. So the clinical trial data show that you do not need to wait or give special instructions afterwards. This stuff soaks into the teeth pretty well. But practically, as clinicians, we know that if you put on a medicine and then you rinse it off right away, it's not going to work as well as if you let it soak in. And what I can tell you from the laboratory studies that we've done is that it does take some time for the silver fluoride to soak all the way down into a thick lesion, and it does take days for those silver solids to set up. So practically, I think it makes sense to wait 5 to 10 minutes to let the patient have some water. What I do with that personally is that if a patient's really having a hard time with the taste, I'll get a wet 2x2 and wipe off their tongue. You could have some toothpaste on the tongue. Dr. McLean taught me that beforehand. If you have a very taste sensitive patient or anything else that they like on their tongue ahead of time, that seems to modify the taste experience. But of course, if a patient's like freaking out about the taste, give them some water, figure out how to do it the next time without them having that intense experience. So that's, hopefully that shows you that we don't have an exact answer to that. Practically what I do in my clinic is I say wait at least a minute, and if we can wait 5, great, and then go ahead and have some water. And the vast majority of the time I've covered with some Vaseline or fluoride varnish so that the water or the saliva doesn't get into the teeth, and I try to discourage the patient from swishing to really rinse out the medicine. So you want to let the medicine soak in, but you don't need to wait the 30 minutes that we do for fluoride varnish.
All right, great. And I know I said that was the last question, but one more that came in, and this one's a good one. Just some people have read that you should light cure, and they were wondering whether or not to light cure the silver diamine fluoride because they have read that at times.
Gotcha. At this point, that's opinion. So the idea is that you would uncure the silver fluoride, you would turn it into an inactive but precipitated state with the goal of helping it to stay around longer. And so there's basically kind of two camps on that. One says do it, one says don't do it. It hasn't been studied clinically. What I can say from the laboratory studies, and there are a number of laboratory studies that are emerging, we've done some really careful ones ourselves, is that it seems to have slightly less penetration depth. We thought that it was going to have much less, that the silver and fluoride were not going to be able to get down as far into a tooth. It's pretty minimal difference. There is a difference. It's pretty minimal. What I've experienced is that it just makes a mess. Is that if you just put silver fluoride on and let it set in without hitting it with a light, only the demineralized and underdeveloped areas are going to pick up the stain. If you hit it with a light, anywhere that liquid went is going to turn black, and now you have to work to get the black off of the healthy tooth. And so, just with normal chewing and brushing, that's going to get off in a few days. You can now start getting complicated with your prophy coming in there and scrubbing it off. But to me, it just makes things more complicated, and I can't see a benefit to it. So hopefully that's a long way of balancing that there's no evidence that it hurts, except that it makes a mess. And that a lot of us have been saying don't do that for a while because it makes a mess, and there's no studies on it. The other detail that's important there is that the free silver ion floating around in the liquid is the active silver. And so you're probably not going to get these nice structures, these nice silver microwires. You're probably going to get less of a hard scab layer on the top of the outside of a cavity. But you are probably going to have enough medicine in there that as the bacteria try to reinvade, it'll reactivate and kind of do some of its magic. So that's my long answer, and the short answer is I don't do it.
All right, great. Well, Dr. Horst, we just want to say thank you so much. In addition to all the questions that came in, a lot of people had great comments, and thank you for a very informative presentation. So thank you so much for that. And thank you for everyone who stayed on for the length of this and joined us today. And just a reminder that your certificates will be emailed out, and to be up to date on any upcoming webinars that we have planned throughout next week and possibly the following weeks, be sure to like us on our social media so that you can kind of stay up to date and be able to be a part of these. So thank you, everybody.